Greetings, everyone. It's your favorite optometrist, Dr. Darryl Glover. Today is a very special treat for you guys. I'm very excited because today we have an expert. And when I say an expert, I mean expert. Today we have Dr. Thomas Hunter. Dr. Thomas Hunter is an ophthalmologist based here in the Raleigh-Durham area, and he works with Duke. And I firsthand have referred him a million patients, whether it's glaucoma, whether it's cataracts. And let me tell you, every patient that I refer to him is always happy. Every week I'm calling him, telling him about a patient that has just been thrilled by his bedside manner, his expertise, or the results that they've had from any type of procedure, whether glaucoma or cataracts. Friends and family, Black Eye Care Perspective, I'd like to introduce my friend, my colleague, Dr. Thomas Hunter. Dr. Hunter, how you doing this evening, sir?
I'm doing all right, man. Good evening to everybody, and thank you for that kind introduction.
Hey, man, you know I'm speaking the truth, man. You know I don't lie. Dr. Hunter, man, before we get started, just give everyone a little bit of a background of, how you got into eye care, your education, and whatever other information you'd like to share with everyone.
All right. So I was raised in New York. When I was 7, I got stabbed in the eye with a pencil. Yeah, that's kind of on my bio when you look at the video online. But it talks about that whole story, that whole event. Just playing in the playground, got stabbed in the eye with a pencil, and from that moment, pretty much I was all eye care. I spent a lot of time in the hospital, getting, had a lot of surgeries to get the pencil all out. And then my mother, actually my stepfather was a resident at the time, and that's how he and my mother met, because
wow,
all the visits, and then, so they end up getting married, and that's when we all moved to Georgia when I was a teenager. But I worked in his practice for a number of years, did everything from the billing, to seeing patients, to working up and teching, pretty much the full gamut.
Gotcha.
At his practice. And I decided at a very early age that ophthalmology was the way I was going to go. Glaucoma, I don't remember when I decided glaucoma. I'm pretty sure it was in medical school, when I started rotating through, the ophthalmology department, and I got a lot more exposure to glaucoma through Peter Netlin, who's like a big name in glaucoma. And started working in his practice, and then from there, in Tennessee, I went to Howard University for residency and worked with Leslie Jones, who's like the biggest name in glaucoma in DC. And because Howard was, I won't say it's predominantly, but it's definitely heavy glaucoma, it's got a lot of experience, taking care of those patients. And I knew, almost immediately, that is kind of, confirmed everything that I knew in medical school and in residency, that I was going to be a glaucomatologist one day.
Gotcha. All right. So, that's a heck of a background, a heck of a story as well. A pencil in the eye, man, that's something serious. What's the best corrective vision in that eye?
It's 20/20. It's 20/20. Okay. So pencil went in through the upper eyelid to the back of the orbit and missed the eyeball. So just great.
Oh, wow. How about that? Okay.
Yeah.
Cool. Well, tonight we really want to dig and dive deep into glaucoma. Glaucoma is something that really plagues us, in regards to our background, but also just, we're living longer. So, we're seeing more, trends in that direction. For those that may be coming out of school, or if they're more seasoned folks that have been practicing, I just want us to start with just your basic breakdown or your basic glaucoma workup whenever you have a patient come in. What should we do? Because I know I do probably the bare minimum, and then I just shove them all your way. But what's the bare thing that we should do when we examine a patient and they have glaucoma suspicion? And what information do glaucoma specialists really want from us?
The biggest piece of information, so again, glaucoma being an optic nerve problem, it's always any information you can give me about the nerve is the most important information, right? So so if they come in, the easy clues are pressure, right? So if you come in, you got a pressure of 30, we can do the visual fields, we can do the nerve fiber layer analysis, all that stuff, central corneal thickness, the standard stuff. We already know that guy's going to be treated. It's the mysteries that really, the ones who don't have all the the things that may say yes to glaucoma and looking for the subtle details. Um, you know, the optic nerve. So I always ask my patients, I'm like, what, do you have any exams from 5, 10 years ago? So I'm always curious about how, another doctor who has saw this patient, examined their nerve and what they thought about their nerve. If I know you've seen a patient 10 years ago and he had a cup to this ratio of 0.2 and today is 0.5, I trust that, right? And I'm like, okay, my OCT is normal, my visual feels normal, but if I look at your notes, that's a big difference,
Huge difference.
So any doctor who see a 0.2 can tell the difference between a 0.5. Now, the difference between 0.4 and 0.5 may be a little bit more tricky, right? If you said it was 0.4 10 years ago, and I'm thinking it's 0.5, that's going to be a little bit more, tough to kind of make that delineation. But a 0.2, 0.1, 5, 10 years ago, and today 0.5, 0.6 glaucoma suspect, I take those patients a lot more serious that this is likely going to be glaucoma, whether the pressure is normal or otherwise. And so, I see a lot of the patients that have been seeing at Duke for a long time, and just surprised at how many of the doctors who have been seeing at Duke for many, many years, the doctors don't document the optic nerve. No one says, what they thought about it, right? So like, oh, if I just had this information, today, if they had documented that, 5, 10 years ago when the person first presented here, I can tell them yes, maybe no, that this is something. But as far as the history wise, the things I really want to know, any comorbidities like diabetes, high blood pressure, whether they're on steroids, like Flonase. I think we talked about Flonase is, over the counter now. It's a steroid. It can raise the eye pressure. And a lot of patients don't even know that it is a steroid, right? So I want to know, what kind of medications they're taking, the high-risk medications. I want to know, if they've had a history of headaches, which can lead me more down the narrow angle, chronic angle closure kind of pathways. People who do a lot of yoga, and they do inversion, right? Those inversion raises the eye pressure a lot. And so I'm often asking about their, whether they have migraines or low blood pressure instead of high blood pressure. Any signs of Raynaud's, fingers turning blue when it gets cold, we go through all of that. We just want to get the history, do they have a family history, right? Because, if they have a strong family history, that makes that, their diagnosis, risk a lot higher.
Right.
I look at the central corneal thickness. If the cornea is really thin, that increases the risk. And again, a lot of people are getting LASIK. And so they LASIK, they'll have artificially thin corneas, which will throw off the numbers. And so I like to know that. And then again, when looking at when doing the exam, everything from the visual field, optic nerve fiber layer analysis. I check their color vision just to make sure there's no other signs of optic neuropathy, going on. Ischemic optic neuropathies can, artery occlusions can sometimes mimic glaucoma. And so I like to rule out those kind of things as well. So again, look at the NFL and the macula.
Gotcha.
And again, the nerve, is really going to be key.
Well, one thing that I'm not a fan of, and I'll be upfront, I haven't done this since I left school, is gonio. How often are you doing goniooscopy in your exams?
All new patient, evaluations will get gonioscopy, just to figure out what type of glaucoma. Is it open angle? Is it closed angle? Do they have pigment dispersion? Is it pseudoexfoliation? Do they have, increased episcleral venous pressure? I mean, there's so many different mechanisms, reasons to do the gonio just for mechanism alone. Even if they look open on slit lamp evaluation, they can still have plateau iris or something else like that, really narrowing off their angle. And so it's essential. I do it a lot every day.
Yeah, and one other thing, I'm glad that you're on tonight, because I feel like as eye care professionals, we should work closer with, your rheumatologists, these folks that put all these people on, oral steroids, and they don't even say anything about the pressures or talk to the patients about the pressures. And I'm sitting here like, you were on steroids for the last year, and your doctor didn't tell you to come get your pressures checked or your nerves, take a photo of them. I
Yeah.
mean, where did the miscommunication take place? How come this isn't something that's a standard? I mean, like, it just blows my mind.
Yeah, they'll often come in because of the cataracts that form from the steroids.
Yeah, yeah,
That,
get the
that's what brings them in. It's not the glaucoma. It's that loss of vision from the cataract. You know.
Right, right. But do you agree it should be something that we should actually have more dialogue? I mean, is this
Oh
something where I should start writing, letters to my patients, doctors, and just saying, hey, this person's been on a steroid, or you're recommending Flonase? There are a lot of serious side effects with the eyes that we really need to take this stuff seriously.
Absolutely, absolutely. Yeah, the primary doctors, the rheumatologists, are great places to start. I used to give lectures often. My first 5 years, um, I was often giving lectures to family medicine, rheumatology, internal medicine, just talking about that. You know,
Gotcha,
um,
gotcha. So now we know the basic workup, for a glaucoma suspect. The next big question is, like, what do you consider your first line of therapy for glaucoma? I mean, I know there are a ton of drops out there, but there's also surgical options. So let's just start with that and kind of break that down. And I know it varies depending on the type of glaucoma and everything as well, but just to give a good overview.
Yeah, almost 9 times out of 10, you know, uh, you're gonna start latanoprost, right? It's a prostaglandin. It works great. It lowers the pressure. Has zero systemic side effects. Again, most of the time, and we're talking about open angle glaucomas. You're gonna start with latanoprost. Um, the none of the other medications have a lower the pressure long enough and have a and again the best thing about latanoprost, not that it just lowers the pressure, but it kills diurnal variability, and it's once a day. You just can't beat that from a from a medication standpoint. Now you look at the two new ones. You asked the question about Zyvalta, and now you have Rocklatan, which is kind of this combination mechanism, and they're great. I mean, anything that has latanoprost in it is going to be great as far as lowering the pressure. The question is, do you need it, right? Because it's more costly, right? And cost is almost always a major consideration when you're prescribing these medications.
Right.
So again, you can use Zyvalta, you can use Rocklatan because it has a combination, but that's only if latanoprost fails first and it doesn't quite get us as low as we need to get. And you can say, okay, I'll use one of these combination latanoprost drugs to help get me the rest of the way. I almost never, or I say rarely, use laser as a first line treatment. So a lot of docs and have recommended using SLT as a treatment, first line treatment for glaucoma. I just don't recommend it. It's been I've pushed against that for again, if you have to do it, then I think it's okay, right? Like patients can't get the drops in their eyes and they've tried latanoprost, arthritis or whatever, they need something that's going to help get them down temporarily. With SLT or lasers, it's a great band-aid, but that's all it is for me. It's a band-aid and eventually they're going to need to use those drops. And so because they need to use those drops at some point, it's better for me to start them now so that they get used and comfortable with the idea of having this pathology. The last thing you want to do is treat somebody with a laser first, and and then they leave your office thinking, oh, my doctor cured my glaucoma, right? It did this laser, my pressures came down. Now I can just take a
Life is good. I ain't got anything to worry about.
worry about. No matter how much you try to explain it to them, I still see it where patients had some preliminary treatment, laser, and then they come back and they're worse off than not because they just got comfortable. Year or two went by, pressures were still pretty good, then they stopped seeing their doctor and they came back and their pressure was 40 again, and then they've lost a lot of their vision. So for me, using a drop is an acceptance of the condition that they have to understand. This drop is gonna help you keep you from losing your vision, right?
Right.
And you have to be dedicated to it. So again, sometimes there are circumstances where you have to do it, and we do it when it's time.
And what about whenever you have a patient that comes in? I have a patient that come in and the pressure may be like 40 or something high. What do you recommend for us to keep in our office to drop that pressure down immediately?
So we keep latanoprost, Diamox is always the kind of the gold standard for um, rapid reduction in pressure. So I think at the minimum, Diamox pills.
Okay.
They're inexpensive and it's good to keep on and they work great. Any of the aqueous suppressants, COSOP, timolol, brimonidine. Pretty much if it's really high, again, I wouldn't, 40, you know, 40 wouldn't make me so nervous. 50, 60
Yeah,
would,
says
you
the
know.
glaucoma expert, but me, I see 40. I'm like, oh man, what's going on here?
So 40, everything is relative though, right? 40 in a totally cupped out nerve makes anybody nervous, right? This patient
Right.
might get surgery, right? Because, within the next day or two, right? With a pressure of 40. 40 in a relatively healthy nerve, I may start them on something and see them back, you know. Just hit them hard, get it down in the office, pretty quickly, and then leave them on something long term, probably a couple of medications, again, depending on, I may start 2 medications with a patient like that,
Okay.
but everything is dependent, how nervous you should be is all dependent on what that nerve looks like. You look at it and you say this is not good, then they don't. That's the kind of person you should be on the phone call. You should be calling me up saying, let's get this patient in today, right?
Right.
Let's not go through that scheduling hub who's trying to put the patients out for 6 months, right? This patient needs to be seen today because their nerve looks bad.
Gotcha.
Um, but again, there's a lot of factors that will determine how concerned you need to be with that one. The nerve is number one.
Gotcha. I wanted to circle back on something that you touched on. I mean, the latest drugs that are out now is Vyzulta and also the Repressor. I mean, what's your exposure with these? I mean, I know you touched on it briefly earlier, but let's really break it down. The mechanism behind it, how it works, what your perspective is of it is, and how you're utilizing it in your practice.
Yeah, I prescribed Zyvolta again, a couple times. Again, Zyvolta is a combination drug. It mixes latanoprost, with a nitric oxide modality. Latanoprost is going to increase uveal scleral flow, and the nitric oxide should increase trabecular meshwork output. And so again, you theoretically you're getting a dual mechanism of action.
Mhm.
The biggest obstacle to using it was cost. I would prescribe it, and then patients wouldn't be able to get it. Do I think it works? Yes, I'm sure it lowers the pressure, and I'm sure that you know it has a place in the treatment, especially for patients who are like I think you also mentioned about the side effect of Repressor and Rocklatan is the hyperemia, right? Some patients, it doesn't bother me so much when I see it, like your eyes a little bit red, and but the question is how bothered they are by it, right? The hyperemia doesn't hurt the eye, from what we know, but if they don't like it, they're not going to use it, right? And that's going to be that's the key thing. If they see those red eyes and they say, I'm not going to use this drug because I don't like it, then you need to find something else. If they look at it and say, I'd rather not go blind and I don't care if my eye looks red, then you're doing okay. But they work. Repressor, and I mean I like Rocklatan a little bit better than Repressor. I feel like it's low. Again, its mechanism is also going to increase your trabecular meshwork output, but Rocklatan combines that latanoprost, and so you get a lot lower pressures when you use the Rocklatan than just Repressor alone. I'm currently using Repressor more as, again, mainly because of cost and because of the hyperemia, as my last line, right? I'll use latanoprost, COSOP, brimonidine, use all those things first. They definitely try to market it as a second line drug. But again, if I'm going to use it as a second line, I might as well just switch to Rocklatan. So I'll use Rocklatan as second line, and then Repressor as basically my fourth line of treatment.
Gotcha. And how important is diet when it comes to all of this stuff? as far as, getting that pressure to where it's at? I mean, you always read stuff, whether it's diet or running, these little studies that are out there. I mean, does that stuff truly have an impact on the optic nerve? I mean, I can understand keeping your blood pressure under control, sugar levels, cholesterol, because of the vascular theory, getting enough blood pressure or being able to perfuse the optic nerve head and things of that nature. But how much is that really impacting the optic nerve?
Again, for all the things you just said, really, there's a multiple reason why exercise and diet is important. So again, one of the biggest risk factors I feel for glaucoma is going to be diabetes, right? Um, it's just, really, really high correlation between the two, especially low pressure glaucomas. And so I often tell my patients, I don't, just try to optimize their glaucoma. I try to optimize their entire health, because all of those things, increased risk for, vein occlusions, all these things that, again, there's, you're trying to get them with glaucoma. I always tell my patient, I'm trying to keep you seeing all the days of your life, right? So no matter how old you are, you're 30 years old, that's 70 years. I try to get you to 100. That's what I tell everybody. Try to get you to 100, and after that, I'm not going to do any surgery on you for sure, So again, so in order to keep them seeing, which is the ultimate goal, you have to optimize their general health and talk to them, their diabetes, no high fructose corn syrup. And I just stress the importance of that part. And then you got certain conditions like pigmentary glaucoma, where exercise is one of the big risk factors that make that pressure go up. So I often tell my patients to come on in. I say, look, an hour after you worked out, I want you to come on in. Let me check your pressure. Let me see how your pressures are responding to exercise. Because, if they're working out pretty hard, and their pressures are still going up high, and they're still getting nerve damage, then we got a problem. So we have to know what all is happening during the stuff that they're doing. If they're doing a lot of yoga, I tell them no downward dog. You can do it. It's that downward dog that's going to get them. Especially if they're down there for a long period of time, they're doing a lot of it. So yeah, all of those are essential. But just pure diet, exercise. I don't know of any particular foods that's going to lower the pressure. So I don't usually make any specific recommendations. Just more general health stuff.
Okay. The next big thing that folks have had a lot of questions about is just, this MIGS procedure. I know this is something that you were very heavy in when it first came out, and I'm pretty sure you're probably still dabbling in it quite a bit. But
Yeah.
I'm gonna let you just take this from the top and just break it down, and let's just go in detail about it.
Yeah, the whole idea of MIGS, minimally invasive glaucoma procedures, um, is to try to find something, intermediate treatment for mild to moderate glaucomas, right? A lot of times, again, 10 years ago, the dilemma we were in is that you would have somebody with a pretty healthy nerve, really healthy, really high pressures, and you've maxed out on lasers and drops, right? Glaucoma surgeries in general have higher risk, right? So if I put in a tube in the eye, or if I do a trabeculectomy, those surgeries, I mean, if you look at the risk profile, it's pretty high, right? And again, I try to minimize, any risk with any surgery I do, but there's some things that you just can't see coming with those surgeries. And so that left a big gap, right? Like, I don't want to do a trabeculectomy on somebody who's 40 years old, has high pressures, and have to live the rest of their life with this bleb. And so again, so trying to find a way, and that left, a way to get the drainage system working better, the natural drain, the trabecular meshwork working better, came to life. People said, okay, let's start working in that space, and we worked in that space previously. And again, what I remember when I was training, they said, there aren't any good surgeries that work in the trabecular meshwork, and so we don't do them. And so I was like, okay, that's just it. And then the MIGS came out, and it was like, oh, we're trying all this stuff. And and again, stuff, and I think that's still the experience. We're working in this space, but yet we don't have any home runs, right? We have a bunch of stuff that works for a short period of time, and then everything goes back to the way it was, right? So I think that because why are there so many MIGS procedures? It's because there's not one good one, right? You know, eye stents. You know, we started out trabectomes. Now they have the hydrus and the hook. Again, all looking to get more flow through the trabecular meshwork. And I wish there was one that I can rely on. I still do them because I think it's, I mean, they're relatively low risk, you know, a low risk addition to cataract surgery to try to get that pressure down and potentially keep them from having to do more advanced glaucoma surgeries. You know, every glaucoma has its season, and that's just not the season.
Gotcha.
You know,
Gotcha.
but yeah, I really do. I think we all do. We want something for mild to moderate glaucomas that don't involve, creating a bleb.
Gotcha. Now, there was a question from Dr. Adam Ramsey. He said, what do you think of the Alcon trifocal lens?
You know, I haven't used it, and for one reason, one reason only. So there's, I guess, the two big dogs when it comes to premium lenses are going to be the AMO lens, the Symphonies, the multifocal lenses through AMO, and Alcon, right? We all know the problems with these multifocal lenses as far as, glare from lights and things like that. And it's probably been the most, unfavorable side effect of using a multifocal lens. That, and, they're spending, upwards of $7,000 to get both eyes done. So cost is always an issue. So, as far as working, I think that they all have a tendency to work. If you put it in the right patient, they can work. Me personally, I never really liked the Restore lens. They kept changing the models, and the side effects I felt always outweighed my benefits with the Restore. And you get some patients who are really happy, then next day you get somebody who's like, this thing is not working for me, right? And so I decided to switch, and I switched over to AMO lenses, and been super happy, and it's like, I don't use many I use the Alcon Toric. I still think it's pretty good. But the AMO lenses, the way they make their haptics, it centers so well in the bag that patients just love it. Like, patients are always just super, super happy with that lens. But because of the way it sits in the bag, it has the ability to rotate, which is not good for torics. So that's why I still use the Alcon Torics, which stays pretty stable in the bag. But they're changing their lens. I talked to one of the reps in AMO, and they're polishing. They're gonna remove that polished finish from the haptic so it doesn't rotate in the bag as much. But again, rotation is not a big issue because we take all the viscoelastic out of the bag before we put the lens in the eye. So again, it's not a big problem, but it's always the one thing that makes us concerned. So with the PanOptic, it's a new lens. It's still an Alcon lens. They say that they've fixed a lot of the problems they've had with the Restore. And you don't have to now, because previously we were blending the technologies. We'll put like a Symphony in one eye, which gives you great computer distance, and we'll do a multifocal in the other eye, which gets you a little bit better near vision. So we had a computer vision in one eye, computer and distance in one eye, and near and distance in the other one.
Okay.
And it was blended technology. So when they came up with the PanOptic, we said, okay, we now don't have to blend the technology. We put the same lens in both eyes and still get that full range of motion, so full range of vision. And so I think the idea is great. The question is, I'll look at the design of the lens and it looks the same to me, right? And it's the design I never really liked about it. I've gotten, I've gotten some feedback that says, they don't notice any difference from the Restore. And again, when I told the rep the other day, I said, if it's not broke, don't fix it. And right now, when, my AMO Symphony patients are so happy that I don't feel the need to jump into that arena right now. If I start getting patients that are just saying they're unhappy with using, with my blended technology that I still like using, then maybe I'll consider it as an option. But right now, my patients are just 20/20 at all levels and at distance, computer, minimal side effects, and just happy. So, with those lenses. So I don't feel the need to switch over at this point.
Well, I like that concept of using different, options for people because everyone's eyes are different. So to have one lens that you go to for everything, it doesn't make sense. It's no different from contacts.
Right.
So, there's different lenses for different folks. So I mean, you just have to really play around and look at lifestyle to see what makes sense.
The lifestyle is that's the biggest thing. You put the lens in the eye, like the symphony. I always, I'll come in, I'll put the symphony in, and I'll ask them, what do you see? It's like, well, I see great distance, I see great computer. Then I ask them about the reading, and I say, hi, if you had to read at that distance your entire life, would you be happy? If they say, oh yeah, that's great, and sometimes they do, I can do another symphony in the other eye. If they say, I do a lot of near work, and I want it to be a little bit closer, right? Like I want to be more here, closer here rather than, in that computer intermediate stage, then we can put something that's a little bit more blended and give a little bit closer lens. The lifestyle, you have to talk to your patients about the lifestyle. What they want is key, right? Everybody doesn't want a premium lens. Everybody doesn't want a toric lens. Everybody doesn't want to not wear glasses, right? Which is, that's somehow became a standard of cataract surgery. It's not just improving their symptoms, is can I get you out of glasses? And everybody doesn't want that.
Right, right. Now, I mean, how do you feel as an ophthalmologist, cataract surgeon, glaucoma surgeon, with your optometrist actually having a conversation about the different lens types prior to seeing you? Does that like mess you up in regards to all your measurements and things of that nature? Or, like, I mean, because I never give them any education. I just say, hey, whenever my parents need cataract surgery, this is what I'm referring them to, and I just leave it at that. All right.
Yeah, the more information they have, and we give them when they're coming through for their evaluation, we give them videos to look at. We send them videos, look at all this stuff. We want them to have as much information as they possibly can before they get to me. Again, but we talk a lot in the room. But it's always helpful when they understand. You're not explaining everything from the ground up, and that they understand some things.
Gotcha.
So for me, it's very useful to have as much information and to know what they want. Some people know that they want to be out of glasses. Some people know that they want their astigmatism treated. And I usually leave it at those. I try to make the explanations as straightforward as possible, right? Like, is glasses freedom a thing? Is something that you want? Yes or no? If it's not there, how about, astigmatism treatment? This is what astigmatism is. We can correct it at the time of surgery, and just try to make it as straightforward and break it down in a way that they understand the options. A lot of times, I feel like patients don't understand the options, and it's that explanation, how much this costs and what you're going to get for that cost. And, toric lenses are $1,000. Multifocal lenses are about $3,600, to put in, and it's not a small investment, right? And a lot of these folks are retired, they're living on a budget. And so they have to know, you can wear readers, or we can do like a mini mono. I found that mini mono works great. Distance in one eye, like a -1, not so far where they'll notice, the difference between the two eyes. You're still like, -1, you're still more 20/40,
Right.
but you still get that computer distance, and you can use that extra reading by. I think it's great to do mini monos, for people who haven't tried like a full mono vision. So, I mean, there's so many different options.
Gotcha. Another
And
question that we had was from Dr. Kobe Cleaver. He was saying, is non-compliance enough of a factor to consider glaucoma surgery? I know you kind of touched on that earlier, vaguely.
it depends on the reason for their non-compliance. If somebody tells me, I mean, you know, yeah, if they're not adhering to their drops, some people say, I've tried it, I can't do it. They come to their visits, they let us check it out, and things are still getting worse, and they're trying. Then yes, surgery is definitely the way to go. Like we can't let folks go blind because they don't want to put their drops in their eyes. Now, the same person I still think would be a good surgical candidate is a person who's not using their drops and they're not coming to their appointments, and that's always the tricky one, because you don't want to do surgery on somebody and never see them again, right? They'll get an infection, they'll have complications, they'll go blind, right? I got one rule when it comes to surgery: is never, don't make things worse, right? And some
Right.
surgeries can make things worse. I could do perfect glaucoma surgery on somebody, and their vision can get worse, especially if they have 5 degrees of vision left, right? And so you have to let them know that these are a risk. But so those patients who just don't come to their appointments, again, the pressure's high. You almost have to do something. I may not do the surgery that I want to do, which would be trabeculectomy in that kind of situation. Tubes have a little bit safer. If you put a tube in their eye and they don't show up, they'll probably still be okay, even though there's some risk of hypotony with that too. But I would talk to them. It's just a long conversation. And education is the biggest tool that you have with these kind of patients, and I often ask my patients exactly what do you want? I'm telling you about this thing called glaucoma. I'm telling you you're going blind. What would you like me to do for you, right? And if we can get on the same page, that's awesome, right? As far as because if you don't have the patient support, you really can't do anything. Right, they're their best doctor any day of the week.
Gotcha. And I know earlier you kind of chimed on this, or mentioned this a little bit. If they have some type of tremor or something where they have difficulties getting it in, then you're good to go in regards to doing some type of laser surgery to at least try to help out to accommodate their lifestyle, right?
Absolutely. Find out what the obstacles are, right? Find out what the obstacles are. That's the biggest thing, right?
Gotcha.
Whether it's tremors or they live on their own and they don't have somebody to help them out. Social issues. Find out what the obstacles are, and try to find a way to whether it's through laser. Again, for more mild glaucoma, or something in the operating room for more advanced glaucoma.
Gotcha. We got another question here. Is blue light protection a factor in IOL selections?
Say again?
Is blue light protection a factor when it comes to selecting the right lens?
That debate has been around for a long time as well. If you look at, again, Alcon, lenses, had that blue light filter. So for years we used only Alcon lenses. I say most people use Alcon lenses that had a blue light filter in it. It was just kind of automatic for cataract surgery. And then all these reports started coming out about how the blue light filter wasn't the best lens to put in the eye, how blue light filters increased depression rate, increased, you got sleep patterns that are all off because of blue light filtering, right? And that we need that. We need some of that blue light. And then, so right now the AMO lenses that I use, that's the PC Boo, AMO lens, they don't make the blue light filter. Their lenses are clear, right? For that reason, again, the debate is whether it's beneficial or not. And right now, some of the manufacturers are moving away from the blue light filters, because they feel like it may be causing some problems. So right now, I don't use the blue light filter lenses.
Okay. All right. Next question. Is there a slow release injection of let me repeat that. Is there a slow release injection of medication a possibility to eliminate the need to use drops after cataract surgery?
Not currently, but definitely that's a big area of research, and the sustained release, I think they're looking at bromonidine as a sustained release. I don't know why they chose, bromonidine, as the drug of choice. It wouldn't have been, but again, I don't do research, and so I can't really tell what their thought was when they were thinking about this stuff. I haven't seen all the papers yet, but I know I've seen a lot of stuff kind of coming out, and looks like bromonidine is the drug that they chose for sustained release, which will be, again, a game changer. I don't like bromonidine as a first line or for this mechanism because it's you don't really get diurnal reduction throughout the 24-hour period. It has a wear-off effect, and pressures tend to go up higher in the night. So I don't like that. It's kind of like Timolol. You know, I don't like Timolol for that same reason, right? It works great, between the wake hours, but when you go to sleep, the effect wears off and the pressures go back up while you're sleeping. So, for that reason, again, they chose that, but that is something that that's on the horizon.
Gotcha. Folks that are on right now, we have Dr. Cleaver, Dr. Blanc, Dr. Humes. Any of you guys have any questions, feel free to take your speaker off of mute and feel free to fire away with Dr. Hunter while we have him at our fingertips. Again, he's well-versed in glaucoma, cataracts. He works at Duke. It's one of the best facilities in the world, in the nation. So if you guys have any questions, feel free. He's at your disposal. I know Kobe Cleaver, he's big in disease, so I'm pretty sure he has something else up his sleeve there. But feel free to fire away. And Dr. Hunter, any other tips or anything else? So it looks like someone's coming off. Go ahead, Dr. Blanc. Feel free to ask.
I don't hear anything here.
I don't hear him either.
What about now? Can you hear me?
Yeah, we can hear you.
Perfect. Yeah. Dr. Hunter, down here in South Florida, you have some of the ophthalmologists, cataract surgeons that you probably spoke on it already, and I just missed it. They're talking about same day cataract surgery operation on both eyes. What are your thoughts on that?
Yeah, I'm not a fan of that. I mean, Florida is a booming area for cataract surgery. Sun is high, and there's a lot of cataracts in Florida. I understand the demand, but again, so my thoughts on any surgery of the eye is risk versus benefits. The biggest risk that you can have in cataract surgery is that for infection, right? The infection rate is low. It's very low, but it's not zero, right? You're going to see patients who are going to get infections. The last thing in this world you ever want, if I saw one in my lifetime, it would make me sick, and that's bilateral eye infections, endophthalmitis. And so for that reason, again, we don't have those. I've done bilateral glaucoma surgeries before. That's basically because something had to be done immediately in both eyes because they had severe glaucoma in both eyes and they didn't have the luxury of waiting. But for cataract, there's no good reason, in my sense, in my practice, why I need to do both eyes at the same time.
Thank you for your input.
No problem.
Yeah, I missed that one. I didn't know about that. That's kind of scary, man.
It is scary. Another question, Darryl, did you ask Dr. Hunter about the question that Dr. Locke on the
Yeah, let's talk about
WhatsApp
that a little bit,
spoke about?
Yeah, the one where it was the diabetic retinopathy, there was glaucoma, there was cataracts. There's a lot of information going back and forth in regards to that. But if you could just give us an overview of what you read and how you would actually pursue that.
There's a lot of you can't put all the information in a text message,
Right.
but there's a lot of so the question is all the gaps. So the questions I really had was for the right eye, why were they light perception in that eye? Was it an artery occlusion? Was it a retinal detachment? Maybe I missed it in the text. What was the reason why they went blind in their right eye, light perception? Because that really, really sets the stage for the left eye leading in the same direction. So figuring out that mechanism. I assumed from the pressures being so different that it was probably a retinal detachment, but I didn't read that. I think the pressure was like 15 in one eye and 7 in the other eye. And you see that big difference between the eye pressures. You kind of have to. For me, I first assume that there's a retinal detachment, but again, I don't know. But in general, and then, the level of retinopathy, in the healthy eye. Cataracts are always elective, which means they can wait, just about any time, right? So it doesn't have to be an urgent evaluation for cataract. The two things, I think the nerve was like a 0.7 and the pressure was 15. So again, from that perspective as well, it sounded like the glaucoma was also mild, and I couldn't tell whether they were on drops or not. So pressure's 15, relatively healthy nerve. It sounded like the diabetes was the bigger concern, because you want to, 10 years ago, the way we handled things were, if they had diabetic retinopathy, any kind of retinal swelling, CME or CSME, then you had to treat the CSME before you did the cataract surgery, right? And you had to do that we had to do focal laser treatments to the retina in order to get that diabetic swelling under control. Now, again, that's the way they used to do it. A lot of retina doctors aren't doing focal laser treatments any longer. The almost the standard of care now will be injections, retinal injections. And so if, the retina needs it, then you give it a couple of months, for the retina doctor to stabilize the retina. And once they see whether things are improving or not improving, depending on how bad the cataract is. Now, if it's a, really, really advanced cataract, the retina doctors, they will tell you, I can't see into the eye because the cataract is so bad. I'm gonna give this patient an injection today, and they can have cataract surgery usually 7 days after the injections, and that will help to keep the diabetes under control, so that you don't have worsening diabetes, from the cataract surgery, which is definitely a thing if you don't try to do something, ahead of time. Again, this is this patient's only eye, so you want to make sure that everything you do is as safe as you can possibly do it. And make sure that you have that extra protection with those retinal injections before you go into the operating room. But I never move forward until I have the retina doctor's clearance. If, again, depending on, I think in that example, the pressure was 15 with a 7 nerve. Again, I need to figure out, one, if there's glaucoma. If the pressure was higher and we knew that they had glaucoma, then again, I would try to optimize them first with drops. I think it's almost always better to, treat with drops first, do cataract surgery and stage it. So you can do cataract surgery and then glaucoma surgery. I try to avoid, I'm talking about, non-MIGs. Yes, you can do MIGs if you felt like the pressure was high and you want to do something else with that. But if I had a more severe glaucoma, I try, if it's possible, to stage it, do the cataract surgery first, and then come back later, 6 weeks later, and do the glaucoma surgery, if the optic nerve can tolerate that. But yeah, it's just a lot of different layers. For me, the key is that right eye. What was going on there that's got your light perception?
Well, I'm pretty sure we're going to get some answers sooner than later. So we'll definitely stay on that case, and we're all in the group, so we'll be able to follow up with that.
Yeah.
Dr. Cleaver, you had a question. Go ahead, fire away, man. It's on you. I don't know if he can. Oh, here we go.
Yeah, can you hear now?
We hear you, man.
All right, cool. Good evening, everybody. I want to ask you, has there ever been an instance where a patient's medical history kept you from doing a particular surgery, i.e., uncontrolled diabetic or uncontrolled hypertensive patient? It seems like the magic number around here for diabetics is an A1C below 10, and they'll be willing to operate on you. But then I don't know if that's any hard rules or hard facts, or they're just kind of like surgeon preference.
Yeah, again, if the hemoglobin A1C is high and they don't have much diabetic retinopathy, I think that's, again, we try to optimize it. I often send my patients to their primary doctor and tell them to optimize this if they can, get them on something. But it's not a hard stop. The hardest stop is the uncontrolled hypertension, who needs surgery of any kind, cataract surgery or glaucoma surgery. I had a lady, the anesthesiologist canceled her. We were about to roll back, and they were like, look, her blood pressure is like 250 over 100 and something. She has poor access. She doesn't remember the last time she's been to her primary care doctor, even though we talked about it. And her son was there, and I was like, well, she won't go. I was like, well, we talked about this. Like, yeah, I can't make her go. I'm like, well, you got to do something, And she won't put her drops in her eyes, and she's clearly demented, So I'm trying to convince him that, she needs assisted living, but she doesn't want it. But, I'm saying, she doesn't know what's best for her at this point. She's demented, right? So, she's going to either pass away or go blind before we figure this all out. And so I talked to her primary doctor. I told him the situation. And I said, look, her pressures were really high. She's got totally cupped out nerves on both sides. Anesthesiologist is not going to let us do the surgery because she has a huge risk of a suprachoroidal hemorrhage if we don't control her blood pressure, right? Which would make her go blind immediately. So again, the rule is do no harm. And if the risk outweighs the benefits, don't do it, and so we postponed the surgery. I said, we'll figure out something, but if she doesn't lose it before we get back to the operating room, then, God bless it.
It's a great question, Dr. Cleaver. Any other questions for Dr. Hunter? Dr. Humes, any questions at all? I see someone's number. I don't know who that is.
It's probably me, Dr. Peters.
Oh, Dr. Peters, how are you doing this evening?
Hi. I have a question. This is not because I have a lot of patients who always ask me about marijuana. And yes, I've read the studies and everything, and they're really serious about marijuana and glaucoma. So do you get a lot of those, Dr. Hunter, or no? It may just be in the area I'm in.
No, it's marijuana and glaucoma has been married for a long they've been married for a long time, Everybody wants it, especially now with, it's becoming legalized in a lot of states. And so, the reality is that, it does lower pressure, but it doesn't sustain. Again, we're all about, the reason why we love latanoprost so much, because it controls it, and it controls it for 24 hours. It's that variability. You would have to smoke, every single hour, in order to keep it down. Glaucoma is a chronic, long-term, many years of treating it, control condition, right? One patient said she's okay with that. She said she'll smoke it every hour. I said no.
Yeah, I tell them it's not going to make a difference, but they're like, are you sure, Dr. Peters? I'm like, yes, I'm very sure.
Oh, my.
You never know when your patients are joking, but there was I remember this instant, it was about 7-8 years ago, and they were starting to use Marinol, which is it's a pill they used in cancer patients, I believe, to increase their appetite. It's a marijuana derivative. And I've been seeing this lady for a while, and pressures were always doing just enough. She came in one day, and her pressures were great. I'm like, man, your pressures, I ain't changed. It wasn't me. I didn't do it. What's changed? And she told me that she started using Marinol. Her doctors were treating her cancer with that marijuana derivative called Marinol. And, and I was like, wow, this is a great opportunity for research for this, for this drug. I mean, I don't know, again, long term, I don't know what's happening in the 24-hour period of her using this medication, how it's lowering her pressure. But in that one instant, that N of 1 patient I've seen on it, she definitely was a lot lower. So I think that, again, with what the future, and again, I wish I was a researcher, because that's the kind of stuff that I would probably want to look into is, are there any viable modes of delivery for marijuana as a treatment for glaucoma. And especially, again, I would probably, it's the kind of thing that you would probably use more for, your end stage kind of glaucoma patients, not the ones that are, that, again, the other drugs are working well for. But, again, 10 years from now, I'm almost certain we'll be having a different conversation about how marijuana is being used in the treatment of glaucoma.
What are your thoughts of CBD oil? Is there any research or data out there that helps out as well? I know that's the big thing now. That everyone is saying that it cures everything that is known to mankind.
Right. That's just the environment we live in, right? So it's that kind of thing where this is the new age. We're in the marijuana age now. So again, 10 years, we're gonna see all kinds of stuff coming out, and everybody's trying to make money off of things, and they don't care how it affects, the people. They care about the dollar, right? So you gotta be careful not, to get caught up in the money part of it.
Awesome. Any other questions? I mean, these are all great questions and great answers. But any other questions before we end this webinar this evening? All right. Well, looks like that's a wrap on the questions. Dr. Hunter, any words of wisdom in regards to glaucoma, cataracts, for all the eye care professionals out there in the world?
Words of wisdom. Again, with glaucoma, the biggest things from my end is going to be, really documenting the nerve. The nerve is the key. So as much back history as we can get on the nerve gives us a lot more information when evaluating these patients. And then, like you said, you call your patients, you follow up, those patients who definitely have high pressures, definitely have optic nerve damage. They tend to fall through cracks a lot. And that should never happen. It's always sad, to see somebody who could have been treated, 10 years ago coming in blind today, right? So never miss an opportunity to treat. I love our relationship, have those close relationships with the glaucoma docs, because that's the one that can get away, right? So call your glaucoma doc, let them know if stuff needs to get in, we need to get it in. But that's about it. It's a tricky condition, and I hate to see patients go blind from it, but you can't save everybody vision. The people who go blind from glaucoma are the ones who come in blind, right? Or come in blind in one eye and severe glaucoma in the other eye. That's the number one thing. So early treatment is going to be better treatment. People who don't use their drugs, their drops, people who don't follow up in their appointments. I keep a list of all my very high risk patients, and I make sure that I cycle through my list, every quarter to make sure that I'm not missing anybody. I know there's one guy named Rodney. And I'm like, Rodney, where are you, man? I hadn't seen you in a while, right? He's in my brain because I know he's the dude who's not going to show up, and so I have to look out for him, because he just, to him, he's young and just doing his thing, but and he knows that he's got severe stuff, but you got to make sure he's staying in there, and so that follow up, and have those two groups, the high risk and the ones that are okay, and they're not losing vision rapidly,
Yeah.
So again, follow up, the nerve, are all keys, to how to treat glaucoma.
I have one last question. I've been meaning to ask you this. I meant to ask you this last time I saw you when we were out. We have these patients that come in and they have tilted nerves or slope. These are always the most difficult for me to figure out if I need to send them to you or not. How are you addressing those folks that come in that's very myopic and they just have that tilted disc and you think it's glaucoma, but it might just be the myopia? I mean, how are you assessing these? What's the best way to tackle that situation?
Well, OCT is not, a lot of times, not useful.
Yeah.
Because, it just doesn't really, again, it depends on, the nerve itself is, in glaucoma, the nerve change. A lot of times you just be monitoring those patients, just long term. You're looking for changes, right? The visual field is more useful, for those patients. So I'll, get visual fields every 6 months, once a year, looking to see if things are changing,
Okay.
right? If they've lost vision, and the nerve looks suspicious, then, likely they're going to be on some form of treatment for glaucoma, Again, the pressure is going to be the other X factor, right? You can have low pressure glaucomas and you can have high pressure glaucoma. So again, your decision to treat is not necessarily based on the pressure. It's based on whether I see changes in the way the nerve looks. And again, that's this meticulous documentation of what I see at the optic nerve, vessel overpass, notching of the rim, disc hemorrhages, the things that you're really looking for to see, is something happening here, or is this just a myopic nerve? You'll see on my notes, myopic confounders. And so if I think the OCT is just not quite right, it's showing some thinning and I'm not convinced about it.
Yeah.
I'll just put that confounder as information. This is a red flag for me that don't, take it with a grain of salt, but again, the visual field, the nerve changes, the pressure, if there's any fluctuations there, all of those things are going to be the key.
All right, cool. Well, Dr. Hunter, thank you dearly, man, for hanging out with us today with the Black Eye Care Perspective family. We gained a lot of great information, good insight. We really love how you broke down everything from top to bottom, from what we look for in glaucoma patients, the starting or the top ways of treating them, when to actually have some type of surgical procedure done, and all the insight that you gave us in regards to cataract treatment as well. Thank you again.